free and widely available high quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2, 1.
Well, good morning, everybody. My name is Jens Chapman. Today is Friday, April 4th, around the world, and a cordial welcome and thanks for joining us at this very special edition of the virtual, that is, Global Spine Journal Club. And this is a fantastic chance to kind of look at the accomplishments of now well over 10 years of Global Spine Journal. And it's a particular pleasure of ours to introduce you to one of our associate editors, Dr. Ishak. He used to be a fellow here years ago and remains one of our absolute favorites and is a fantastic academically and surgically superbly productive colleague. He's professor, and he's going to take us to the heart of Germany, to the University of Heidelberg, and now with his expansion to Wiesbaden. And he's done some really cool research. He's going to reflect on what the literature in the Global Spine Journal shows as to octa and nonagenarians, a reality that we're increasingly faced with. And he's done, with his usual great scientific acumen, some really good research on this to help us make our decisions and guide our patients. He's going to introduce us to his team, and I'm very excited to see them in virtual person because I've seen their names in the literature. Professor Ishak, good afternoon to you in Germany, and please take it from here.
Yeah, thank you, Dr. Chapman. It's always a big pleasure to be back, I would say, at home. Yeah, today we're going to start and we're going to present some in part of our series of octogenarians. And we know it's an increasing patient cohort. And when we were discussing that 5 years ago, it was actually not that frequent as we have it today, because this week, for instance, I've seen like at least 5 or 6 over 80s and at least 3 over 90 years old. So it's an increasing problem and we have to face it. There's a high demand for surgical treatment because we know that those elderly patients are nowadays very, very active and not sitting at home or in front of TV anymore. So today we're gonna start with Dr. Lenger. Dr. Lenger will present her own research, and Dr. Lenger is a highly dedicated neurosurgeon at Heidelberg University with a strong focus on spine surgery in an elderly cohort. And her research particularly addresses spinal pathologies in the elderly, emphasizing individualized and evidence-based treatment approaches in this growing patient group, as we know. So we're gonna now present our own prospective case series of over 180 patients to assess frequency, nature, and risk factors of adverse events following spine surgery in patients over 80 years and older. So Dr. Lenger, please go ahead.
Thank you. Good morning, everybody. Good afternoon, Europe. Thank you for the opportunity to be here. I'm a 6-year resident in the Heidelberg University Hospital. I'm glad to be part of this session, and I would like to thank first Professor Ishak and the Seattle Foundation to be a part of this. Today, we are going to present our results, our findings concerning the surgical management of octogenarians. This data comes from our institutional database and is a prospective study. I have nothing to disclose. Some background information. As you know, according to WHO guidelines, we know that older patients will rise. They are going to double almost from 12 to 22% worldwide by 2050. Surgery in the elderly is always a risk, independent of the surgical field. Octogenarians especially are facing high risks of complication after surgery, and especially after spinal surgery, and there are no clear guidelines concerning spinal procedures in octogenarians. All the data comes from retrospective studies or large administrative data. And as you can see, complication rates are reported between 3 to 29%, and this is a huge variety. So you can see that we have an obvious opportunity for improvement because we need to clarify outcomes and risks that are vital among this cohort, because we have to reduce complication and mortality, we have to optimize healthcare resources, and we have to establish surgical guidelines. To our study goals. As I said, we have already prospective institutional database collecting data from all patients. And for the purposes of today's session, we're going to report exclusively on octogenarians undergoing spinal surgery. We want to analyze clinical trajectories in order to evaluate patient progress post-surgery, to track detailed outcomes in order to enhance patient care. It is also one of our goals to identify morbidity and mortality rates in order to determine the complication rates and to provide evidence-based medicine. Uncover key risk factors is also really important because we have to find the factors that can lead to adverse events, and all that can support the evidence-based preventive strategies. To our methods, as I said, this is a prospective database collecting real-world and real-time data from all of our patients. It began the database 2021, and every resident must fulfill some documents concerning the presence of adverse events independent of the management. That means every patient from our department has a document with adverse events independent of conservative or surgical management, and then these documents are reviewed by the senior attending neurosurgeons. In our department, we are 18 residents and we have 15 certified neurosurgeons. To our results, we included in this time frame over 1 year 184 octogenarians. As you can see, we have a predominance of the male gender, and the elective management had the highest prevalences, with 150 patients having elective spinal surgery. If we take a look at the comorbidities, you can see here that every patient had at least one comorbidity, with the heart diseases having the highest prevalence. So you can see hypertension, almost 0.5% of the patients, followed by different heart diseases, then diabetes, COPD, etc. If we sum all this up, you can see that we have a Charlson comorbidity index of 8.1, and that's really high. That means that these patients are at the high risks for facing complication rates after a surgical procedure. Then we'll take a look at the localization of spinal procedures. You can see that 65% of the patient had a lumbar pathology, followed by cervical pathologies. And for the rest of the cervical spine, you can see that we are moving with same prevalences between 4 to 7%. Very important slide. What did we do with this patient? You can take a look at this pie graph. You can see that almost half of them, blue color, had a dorsal approach. If we take a closer look to this graph, you can see that almost half of them had actually a simple decompression. Complex procedures like instrumentation or 360 degrees instrumentation were with lowest prevalences, moving between 14 to 3%. This is reflecting also to the surgical duration. You can see that the mean surgical duration was about 171 minutes. The necessity of blood transfusion intraoperatively was present in 10 patients. And then you can see we have really short ICU stay, half of a day. The mean hospital stay was about 9 days, and 4 patients died. Here I want to highlight that these 4 patients did not die because of the procedure. Primarily, they died due to the underlying conditions, meaning heart attack or a pulmonary embolism, etc. Then we wanted to see surgery-related adverse events. You can see here the graph every condition that we included, we allocated into degenerative, tumor, trauma, and infection. And here you can see the different categories of adverse events that we are actively documenting: wound events, dural leaks, postoperative infection, malposition, etc. You can see that the prevalences are moving almost samely between the groups, but it's really interesting if you take a look in the category wound event. You can see that almost 30% of the patients that had an infection, meaning spondylodiscitis or spinal abscess, had an infection and wound infection after surgery. And here is the question: did we do any further surgery for these patients? Should we revise these patients? And here we can take a look in the revision surgery rates, and you can see that almost every patient that had an infection had a revision surgery, as well as the rest of the patient with degenerative diseases or tumor or trauma. But if you see the other categories, you can see that we can do a Watson weight management or a conservative management. A revision is not mandatory. Then it's really important. We said we have a Charlson comorbidity index of 8. It's really high. Did we have any non-surgery related adverse events? Again, we have the same pattern. We allocated the patients by pathology. You can see different colors for the pathology. And you can see again that we have the same prevalences between the groups across acute renal failure, respiratory problems, heart failure. But again, it's becoming really interesting if we take a look at pneumonia patients. You can see here that patients that had as a pathology an infection, almost 15% had a pneumonia, whereas a patient that had a trauma or tumor, they're lower than 8%. That means that the pathology itself, like an infection, because it's associated with severe pain, may be a risk factor for the presence of non-surgery related adverse events. And maybe we have to take attention for this, more attention for this group, because they have to be early mobilized and have sufficient painkillers. At the second stage analysis, we wanted to find out potential risk factors for the presence of surgery-related adverse events. And you can see, as expected, that higher comorbidity rates, longer surgical duration, as well as complex approaches like instrumentation are associated to higher risks for the occurrence of surgical-related adverse events. So, to conclude, the overall incidence of adverse events, according to our data in octogenarians, is around 60%, and significant key factors that are influencing these adverse events rates are increased comorbidities, longer surgical duration, and complex instrumentation procedures. The mortality rates were around 2.2%, as we said, primarily attributed to underlying health conditions and not the surgery itself. And our study, we think that it highlights how important a meticulous documentation of adverse events can be, because we can assess risks and benefits, we can refine surgical strategies, and develop support evidence medicine. Thank you very much for your attention.
Thank you, Dr. Langer. We have seen that like our findings, and this is general, show that these complex procedures and instrumentations are feasible. So we have never had like a breakup or we had to stop surgery. This is pretty rare. I mean, this happens once in a while, but in this series, we could show that these procedures are feasible. But on the other hand, and here comes the but, like our hospital is like a big hospital performing 3,500 to 4,000 surgeries a year. And often the question arises, as this is a single center study, but how are these data transferable to other settings, especially for smaller centers with fewer resources? Do you have an answer for that? Or what do we tell our colleagues and friends working in smaller hospitals, probably not facing that many octo and nonagenarians?
That's a really good question. So one thing that struck my mind, first of all, thank you, Paulina, for your excellent presentation and this thoughtful rendition on the subject. What you have created is a very thoughtful way of creating data gathering. And what we found, and others found also, is that we can't trust hospital databases, they underreport. Creating a learning healthcare environment is a really big deal. So while everybody has different hospital settings, creating a system where there's honest reporting, a non-punitive feedback cycle, and then adjusting your practices is a really big deal. So I want to really highlight your findings in that regard, and just having statistics that are meaningful and clean, curated by clinician scientists is hugely important. My question to you is, how much have you changed practices, let's say, for instance, in pre-op optimization, if possible, or, for instance, in applying what we call ERAS principles, enhanced recovery after spine surgery? So how much has this kind of become a practice for your setting?
I must admit that we, after doing this examination, this analysis, we started to do the smallest surgical procedure for this patient. This means that if a patient comes and has a lumbar spinal canal stenosis, we're going to do first a decompression, because we want only to, let's say, reduce the pain levels that this patient have. Compared to a younger patient, that maybe we will recommend their instrumentation because he has a bit of listhesis, etc. So I will say that adopting this meticulous documentation of adverse events, we changed the view of treating these patients, trying to do the smallest surgical procedure in order to achieve an improvement, a significant improvement of their symptoms.
Yeah, I think this is a good point. So we went from big surgery to less surgery because in terms of errors is like getting the patient out of bed as soon as possible. So this helps avoiding cardiac issues, this avoids pulmonary problems, and get him out of bed as soon as possible. I think this is the goal we all should achieve. Okay, so I would like to go on with Dr. Al-Halabi. He will discuss a retrospective study with a one-on-one propensity score matching, and he wants to tell us more about a study which evaluates whether age alone is a valid reason to avoid spinal fusion surgery in patients over 80, and to compare those results to a propensity matched group between 65 and 79 years old. And just a couple sentences to Dr. Al-Halabi. I know him very well. I worked with him many, many years. And he's a kind of specialized in spinal and human neurosurgery with a particular interest in oncological aspects in spine surgery. And what we've seen in the past years that his work bridges clinical care and translational research, aiming to improve outcomes for patients with spinal tumors and complex oncologic diseases. So Dr. Al-Halabi, please. You're unmuted.
Thank you. Thank you, Dr. Ishak. Thank you, Dr. Chapman, and to the Seattle Science Foundation for having the chance to present in this very respectable setting. As Dr. Ishak has alluded to, so this first presentation is going to discuss a recently, in 2024, published work on propensity score matching of patients who underwent spinal surgery in a Korean hospital, at the Catholic University in Seoul. So basically, the rationale of this study comes from the idea that, I mean, we have heard as well from Dr. Lenga and Dr. Ishak of the growing need for degenerative spine surgery in elderly patients due to demographic changes, and a lot of studies pouring in, also from Dr. Lenga, that show that octogenarians have a higher complication rate who undergo spine surgery. But this study particularly thought about isolating age as a factor that might affect outcomes pertaining to complications, and maybe even out problems of other cohorts that might be too heterogeneous. So the question was whether after an age of over 80 years could be an independent risk factor for complications in spine surgery. I'll just take you through the study flow chart just to kind of try to understand what our colleagues from Korea did. So they started with a cohort of 2,065 patients that they basically retrospectively analyzed over a period of 5 years, 2016 to 2021. And they looked for degenerative disease and basically patients that are 65 to 89 years old. They only took patients who underwent fusion surgery in the lumbar and lumbosacral segments, who also particularly underwent primary surgery. So they excluded surgeries for malignancy, infectious diseases, or revision surgery, and made sure to include patients with at least 1 year of follow-up with sufficient data. They ended up with a group O that I'll be showing throughout this presentation and a group E. And basically, this refers to octogenarians that are older than 80 years of age, and elderlies are the E's, who are 65 to 79 years of age. What they then did is perform a propensity matching analysis. So they matched patients of both of these cohorts based on what you see here: fusion levels, estimated blood loss, transfusion need, BMI, ASA, and CCI, factors that pertain to complications, surgical methods, and operation time, and then ended up with a matched cohort that they analyzed. Just want to take you through the baseline characteristics of these patients. So you see here is the group on the left-hand side, the cohort before propensity matching, on the right-hand side after propensity matching. So I think you would expect age to make a significant difference, but what you see there is that there were differences in blood loss between both patient cohorts, and when it comes to the levels of corresponding transfusion, of course. But in other variables, there wasn't much of a huge difference. But you can sort of notice that there might be small differences between these cohorts, which makes sense to perform propensity matching, which you can see on the right-hand side. So they matched these patients based on these criteria, except for age, obviously, because this is the factor that should be compared at hand. And they ended up with 49 patients. There is a slight error in this article if you have a look at it. So basically, patients with regards to method, these are patients that underwent dorsal instrumentation, although the table says that it's an anterior approach. So in terms of outcomes in matched cohorts, they basically looked at classical parameters pertaining to back and leg pain, especially VAS and the corresponding ODI. And what you can see through the table is that these patients in both cohorts profited from the surgery and had a reduction across all of these scales. The differences in post-operative ODI and leg and back pain VAS after 1 year in both of these cohorts was not significantly different. So both of them profit from this surgery in terms of improving their symptoms. Interestingly, there was a difference in follow-up time between both cohorts, but I mean, this would make sense since the octogenarian patient cohort is a bit older. So you would expect that some of them might naturally be lost to follow up in the course of this study. Interestingly, there was no difference in treatment costs or readmissions of these patients that were significant between both cohorts. Now, when you look at surgical and medical complications of these patients, again, the elderly group and the octogenarian group, what they did is gave in a surgical factor, which is basically the total number of events, and the medical factor, surgical and medical events. There was no significant difference between both groups in terms of the frequency of surgical events, but when it came to medical events, there was a clear high representation of delirium in patients that are older than 80 years of age. This was the only driving factor for a significant difference in the medical factor field. So it's basically a higher rate of delirium that occurred in patients that are higher than 80, older than 80 years of age. So with these findings of the study, I think it would be nice to maybe reflect on the idea of delirium itself in spine surgery that has been also described in bigger studies, also in meta-analyses, looking at a great number of patients, and also in age-matched cohorts. And indeed, this is a finding that has been also confirmed and corroborated by other evidence in the past. I've sort of collected all different risk factors that were implicated in a high risk of delirium in this setting. And I just highlighted ones that weren't included in this study that don't pertain to CCI or ASA, just to highlight some of the things that might help further clinical decision making. So basically, the fact that blood transfusion occurred was evened out by this study, but differences, for example, in terms of electrolytes or intravenous blood fluid volume, neurological diseases in the past medical history, substance abuse, things that one might want to watch out when evaluating such patients in terms of their risk for delirium. So basically, the study shows that age over 80 years does not seem to independently be associated with surgical complications in lumbar fusion surgery. There are some questions that pertain to the aspects of generalizability in this study, especially because there was a small sample size of over 80-year-olds, and basically patients with fusion surgery were included in this analysis. And there mightn't be a transatlantic consensus on this, but we noticed that Europe is moving towards the direction of decompression rather than fusion surgery. This is something also Pavlina has alluded to, but this study was basically designed to look at this particular aspect. So this is I would say a further advantage of the homogeneity of the sample included in this study. It seems as though isolation of age itself could be an interesting factor to have a look at. But again, we know that a lot of comorbidities are age-driven, and the real-world scenario is more complex than just CCI or ASA. Basically, frailty could be also something that one might have a look at when interpreting these studies. And definitely the idea that this study finds is the fact that delirium is a age-independent factor that might occur postoperatively, and the fact that this could be something manageable would alert spine surgeons to maybe look at specific patients where you could anticipate this and stratify for. Nevertheless, this study showed that mere old age itself should not deter from considering patients for indicated spine surgery, especially with what we see in terms of improving their quality of life and their clinical outcomes at least 1 year postoperatively. So I think with the right patient stratification in this context of lumbar spine fusion surgery, it would make sense to consider also octogenarians. Thank you.
So thank you very much for this very, very interesting presentation. And this study, we've nicely seen it, addresses the important question we often face in our daily clinical practice. Is age alone a reason to avoid spinal surgery? We have seen in this study a higher rate for medical complications, especially postoperative delirium, right? Despite that, we had no difference in mortality or surgical revision rates. This is also an important point. So the message in this study is clear: with a good preoperative assessment and attention to perioperative risks like delirium, age alone should not be a barrier for spinal surgery. So Dr. Al-Halabi, I have a question for you. So would you consider in your daily practice, after reading and analyzing this nicely written study, to include something like a frailty index or cognitive screening tool in the future, and to improve risk stratification? Or would you think it's more intrinsic age-related physiological vulnerability problem, right? So we can do whatever we want to do, but we cannot solve the problem. So what's your comment on that?
Thank you, Dr. Ishak. It's quite a quite interesting point you bring forward. I think obviously it would make sense since delirium is something that we see in older patients, that we try and sort of catch it before it occurs and try to prevent it. So I think it should make sense to maybe work with not only patients, but in the case of octogenarians, with their relatives, to really have a look at the whole process of a clinic visit up until surgery and post-operative rehab if needed, to make sure that these patients are given anti-delirium measures and to improve that aspect of surgery. Interestingly, however, even if delirium had occurred in these patients at a higher rate, we don't know, especially from the study, how severe it was, because it doesn't seem as though it increased, for example, hospital costs or the need for patients to stay longer in hospitals or at the ICU. So probably this is something that we can manage and that we can maybe mitigate if we track this and try to catch it up at an early stage of patient visits.
Okay, thank you very much. So and especially for this nicely statement, and this shows clear that delirium is really a problem, but we have to face it, we can face it, and we can face it successfully. So, yes.
Amir, good to see
Hi,
you.
Amir, good to see you.
Thank you, Alabi, for the good presentation. So if you could go back to the matched cohort, I just had one question kind of looking back at the data. Yeah, this one here. Next one forward. So, obviously in a matched cohort, we can't look at everything, but it looks to me that the surgical factor and the revision rates were, although not statistically significant, were quite different in the octogenarian group. Just wondering how we kind of look at these data. Is this just kind of underpowered to really show us a good difference, or is this not really clinically relevant?
For me personally, as I've known the data, we have like 49 patients over 80, and they were matched to 49 between 65 and 79. That means underpower is really an issue, and this probably may lead to those results. Yeah, so this is one point I definitely would say yes, but Dr. Al-Halabi, you have a comment on that?
Yeah, I definitely agree with Dr. Ishak. We can't anticipate how this would look like if we had a higher number of patients. I mean, it could make sense to assume that these patients might bring certain anatomical factors with them, osteoporosis, etc., things that might lead to such a higher rate. But I think at the end of the day, that this is still quite a low percentage to look at. And I mean, everything against one looks high, right? So I would anticipate that this would still be under a 10% level, which is something that we can work with and maybe also discuss with patients, even if not significant here.
Now, we have also taken into account that we have excluded trauma, excluded tumor, and infectious disease. So we don't know how these data may apply to octogenarians with probably more complex spinal pathologies, right? This has to be taken into account too.
Great, thank you.
So now we're gonna move forward with Dr. Noman, and he's one of our advanced spectroscopy guy at Heidelberg because he's focused on advanced spectroscopic techniques, especially the Raman spectroscopy, and he would like to enhance intraoperative diagnostics and neurosurgical precision within minutes during surgery. So not waiting for the pathology, so immediately, right? And his work aims to integrate cutting-edge technology into our daily surgical workflow and for better tumor characterization and tissue differentiation. This is like his main scientific background. So Dr. Norman, so please go ahead, and we're very excited. So Dr. Norman is telling us something about a prospective multi-center cohort study, including 17 spine centers across Germany and Switzerland. And this study group aimed to validate the OF score, like the osteoporotic fracture score, as a clinical decision tool for treating osteoporotic vertebral compression fractures. So Dr. Noman,
Mhm.
the stage is yours.
Yeah. Thank you. Thank you, Dr. Basem. Thank you to this Seattle Science Foundation and Dr. Chapman for this opportunity, for having me. It's really an honor. And if we talk about spine surgery in elderly patients and octogenarians, then of course we have to talk about osteoporosis, right? So that's why I would like to present a publication, as mentioned by Dr. Ishak, a prospective multicentric study that looked at this osteoporotic fracture score and evaluated its clinical relevance and the outcome of the patients. And as we face more and more of these osteoporotic fractures, and we have seen a significant increase over the last decade, actually, and facing aging society, I think we need clear indications for treatment and guidelines. And so far, if we choose the therapy and decide what we recommend to the patient, oftentimes we just use morphology. So this work group across 17 hospitals in Germany and Switzerland actually introduced a new OF score to try and integrate also clinical parameters for the decision making. They included only adult patients with proven osteoporosis, with atraumatic or even low energy trauma in the history. And what they focused on is that so far we have the OF classification and the decision making of therapy by morphology. So we look at the height of the vertebral body. Are both end plates also affected? Is the posterior wall included or not? And then we make the decision what therapy, if we do conservative treatment or surgical treatment. And in some cases, it stays a gray zone and we don't, are not sure what to do. And we just maybe look at the progression of the disease. So this work group actually introduced this OF score, which also includes, of course, the OF classification, and then also other aspects like the severity of osteoporosis, how severe is the osteoporosis, the deformity, and is it progressing or not? Then, of course, the pain. Is the patient able to walk or not? Do we have any neurological deficits? And they gather all this information and then we have a pointing system. And in this scoring system, from 0 to 5 means we have a clear recommendation for a conservative treatment. 6 points means we have an indifferent group, so the surgeon or the physician can decide whether they want to choose conservative treatment or surgery. And then we have patients having 6 or more points that where we recommend surgery. So in this prospective multicentric study, they included 518 patients. 344, so around 66%, were surgically treated, and 174 had a conservative treatment. And in the indifferent group, that means 6 points in the OF score, we can see here that 56 were treated surgically, so and only 19 with a conservative therapy. So in this indifferent group, we had more that received the surgery. And actually, 86% of the actual treatments were according to this OF scoring system. So the doctors in 86% did what this OF score suggested. If we look at the types of the fractures, mostly we had OF3 fractures. And I think this is interesting because especially in these cases, oftentimes it's not really clear whether to go for surgery or to observe the clinical course of the patients. And that's why we need scoring systems like this to have a better recommendation for the patients. So these are the subgroups that were then divided. So I will explain this because a lot of shortcuts. So we have CPL, that stands for conservative compliant. That means the patients where the OF scoring system recommended a conservative therapy and that actually received a conservative therapy. They were compliant to this. And then the CNCPL, that means the OF scoring system recommended a conservative treatment, but the patients actually received the surgery later on. The same goes to the to the surgical part. So we have the surgical compliant group and the surgical non-compliant group. And in the middle, you see the indifferent patients. Again, the ones that received surgery and the ones with the conservative therapy. To look at the results, the working group had a couple of follow-ups dates. So we have 6 and 12 weeks after the surgery and 6 and 12 months. And of course, the initial assessment before the surgery. So they used plenty of tests like the visual analog scale, ODI, but also quality of life, and they assessed all these parameters. And one thing that we can say in general is that all patients in all subgroups, so conservative therapy, but also surgical therapy, improved in all tests. But if we look at the details, we see differences, and we see that we have less effect in the groups where we have non-compliant patients, where the treatment was not according to the recommendation. And what we can see in general is that the surgical subgroup seems to have a greater effect, greater beneficial effect of the treatment. Let's focus just as an example on 2 of these results. Here we have the VAS and the ODI. So you can see is in dark black is the initial assessment before the surgery, and in gray the post-op or the following up of the patients. And you see the different subgroups. And some points I want to highlight. First of all, I think we can see that the surgical subgroup seems to have, right from the beginning, seems to have more severe symptoms. But on the other hand, also we see a greater jump and a greater change in the comparison of the pre-operative assessment and the post-operative assessment, as you can see, for example, in the surgical compliant group. And especially, another point I want to highlight, especially in the group of the surgical non-compliant group, so where the OF scoring system clearly recommended surgery, but the patients did not receive surgery, we see that the differences, the improvements that we have is compared to the other points or other subgroups is less. So I think this is one thing that we can really clearly see, that especially patients where we have a clearly recommendation for the surgery and then not receiving surgery seem to have worse outcome than the patients where we follow the recommendations. Also, if we compare quality of life, also it's comparable. So here, the higher we go, the better. And also the surgical group, subgroup, seems to have right from the beginning, more severe symptoms. But in the end, and this is very interesting, all subgroups end up in a very similar area of improvement. So to come to a conclusion, I think if we treat patients, elderly patients, octogenarians with an osteoporotic fracture, I think it is good to involve not only morphology of the fracture and imaging, but also the clinical aspects, as we heard from the previous speakers, and to assess how the improvement will be, how the outcome will be, and to know what treatment we will choose. And especially in the cases where we are not sure, just from the images, whether they improve or not from the surgery. And in this study, we see that especially the subgroup, the surgical subgroup, improve and has a greater beneficial effect after the treatment of osteoporotic fractures. And with that, I come to an end. Thank you a lot. Of course, open for questions.
Thank you, Dr. Norman, for this very clear and informative presentation. And we've seen in this study that those patients who were treated surgically had significantly better outcomes in terms of pain, mobility, and quality of life. So takeaway home message is clear. OF score, like the osteoporotic fracture score, is a valuable and so far evidence-based tool to support individualized decision-making in those fracture treatments, and which is always easier for us as a surgeons or surgeons on call. It's very helpful in standardizing care for elderly patients. So what we always hear, those Germans are very aggressive. They do surgeries day and night, and the elder, the more surgery. So what is your opinion, Dr. Norman? Do you think there is a kind of overtreatment or a risk of overtreatment, especially in those borderline OF score, like with OF6 cases? Or what is your opinion on that?
So I think a scoring system like this is the important, as you mentioned, important fact is that we include all the facts, right? So not only the images, but also the clinical aspects. And I think if we really include all of these aspects, it helps to do the decision making. And as we see in this publication, I must admit, I think the surgical group showed the best or a very good beneficial outcome. And that's why I think if it's not really sure and unclear, I would not hesitate to do the surgery if nothing, of course, no contra indications are standing to really try and help the patients.
Yeah, that's an important point. So what we see the patient after falling from a sitting height or low back trauma, and he presents himself in our outpatient clinic, you have the feeling when he's talking to you that he did like extreme sports yesterday, and after trauma, he's completely impaired. And here's the problem. So those patient cohorts, they have even more pain, lower mobility, and worse overall health scores. So they are totally impaired and bedridden. So in this sense, surgery, in my opinion, is not necessary overtreatment, but rather indicated for a more severe presentation. And this is the reason why there is a high demand for those patients to do surgical treatment, and they want this surgery, and they're fine with every complications. So, and this is the reason why it's getting even more patient and more surgically treated patients.
Let me ask you a question. Osteoporosis, I mean, serious osteoporosis. Sorry, two-part question, my usual. Number one, how accurate is it to use Hounsfield units nowadays, assuming they're well gathered? And how much is osteoporosis an expression of severe comorbidities, such as dementia or substantial medical comorbidities?
Mm-hmm. Thank you for this question. I think let me tackle the second question before the first one. I think it goes hand in hand. Of course, if the patient, for example, does not have a good nutrition and comorbidities, it will go hand in hand with osteoporosis, especially in the elderly. So if we have osteoporosis in the imaging, I think it's a like warning signal for us to do the digging whether the patient has other comorbidities that might be difficult or make a surgery difficult. And to the first question, I think that with the improvement of imaging and computer tomography, I think still this is the best assessment of osteoporosis we have, and that we can use.
Yeah, just a personal note. We know that Hounsfield unit is reliable, it's comparable and well studied. So even for me, the DEXA scan, which is even more reliable, I don't count on that because I have so many patients who had like a good DEXA scan, bone was weak, bad DEXA scan, bone was good. So I don't rely on those facts. So I still have my tactile feedback intraoperatively and decide on that. Of course, you have to tell the patient there's a likelihood that your bone with 80 or 90 years old is not in a good condition. So we might use whatever bigger screws or cement. Right. This is my personal experience. Okay, so let's move forward with Dr. Maximilian Schwendner. And Dr. Schwendner is very actively involved in research on transcranial magnetic stimulation. So the other part of the neurosurgical part, it's called TMS, and he's exploring its clinical applications and neurophysiological mechanisms. And he's in a very innovative mindset and makes him at Heidelberg to a key contributor to neuromodulation research at Heidelberg University Hospital. Today, Dr. Schwendner will present a multi-center comparative study with over 600 patients, and he wants to explain us something about adult cervical deformity patients and the experience with a higher complication and mortality rate after surgery with cervical deformity surgery, and to compare those results to thoracolumbar deformity surgery, right? By comparing baseline health, frailty, and disability. So, Dr. Schwendner, the stage is yours.
Dear audience, thank you, Basem, for the kind introduction. I'm happy to present you now a paper on the assessment of frailty and comorbidities in adult deformity. First of all, I'm funded by the Clinician Scientist Program of the University of Heidelberg. And today I'm going to give you a brief introduction on the article by Smith et al. It addresses the topic adult cervical deformity patients have a higher baseline frailty, disability, and comorbidities compared with the complex adult thoracolumbar deformity patients. And it's a comparative cohort study of 616 patients. Let's take a quick look at the introduction of the study and on the background of the study. In contrast to studies on patients with complex adult thoracolumbar deformity patients, after on referred as ATLD, studies on adult cervical deformity, later on referred to as ACD, have far more limited experience and studies. The operative treatment of ACD is associated with markedly high rates of complication and all-cause mortality compared to operative treatment of the ATLD. In numbers, all-cause mortality within 1 year of surgery to treat ACD has been reported to be 9-fold higher than for ATLD surgery. In numbers, that's 9.2%, so 1 out of 10, compared of 1%, so 1 out of 100. The explanation for these differences is often based on clinical experience on a perceived worse health state of ACD patient and has not been really explored and demonstrated previously. So the authors of this study, one second please, there we go. The authors of the study aimed to compare baseline measures of frailty, disability, and comorbidities between ACD and complex ATLD patients, all undergoing surgery, and they based the data on 2 large prospectively collected multi-center cohorts. We got 2 multi-center prospective cohorts, all registered through clinicaltrials.gov, so large US-based multi-center trials, which were retrospectively analyzed. What data did we take a closer look at? We first of all took a closer look at the preoperative baseline assessments, such as demographic and clinical data of the patients, including patient age, sex, body mass index, Charlson Comorbidity Index, and the American Society of Anesthesiologists grade. And the next step, we're also taking a closer look at the patient-reported outcome measures, which was consistent of the Veterans ARND 12 items health survey, which is consistent of a summary of physical and mental component scores, and a patient-reported outcome measures information system, PROMIS. In the next step, we also will take a closer look at what the authors analyzed on patient frailty. It's at first the Edmund-Frail score. Quick introduction to those of you who need a quick explanation on it. It's a practical tool to assess frailty in both the inpatient and outpatient settings. It consists of 9 domains, more or less covering all of the patient, from cognition, general health status, functional independence to functional performance, which was measured to the time required to stand up from a chair, walk 3 meters, and return back to sitting in the chair. And you then, in the end, get a rating from 0 to 5, from not frail to progressively decreasing in frailty. And the second score on frailty was assessed, which is the CFS, the Clinical Frailty Score, based on the Canadian Study of Health and Aging, which also ranges from a range from 1 as very fit to 9 as terminally ill. And as a third parameter on frailty, the authors analyzed the hand grip strength. So let's take a look at the results. Here's one of the large tables in the study. So they really took a closer look at more or less everything you could take into account. And we saw significant differences, especially the significant differences I've marked here with the red arrow. So it's gender, the Charlson Comorbidity Index, the ASA grade, and the VR12 PCS, the mean value. On the physical score, then regarding frailty, the dynamometer, which is the hand grip strength, then the clinical frailty scale by the CSHA, and the frailty score overall, and also the category the patient was rated in. And we see in all these categories, the adult cervical deformity patients perform significantly worse compared to the adult thoracolumbar deformity patients. The authors then took a further look at the data and really also not performed univariate, but also multivariate logistic regression, and observed that the patients with thoracolumbar deformity had increased hand grip strength with a odds ratio of 1.029, and increased EFS for the patients with cervical deformity. And female gender also played a significant role in the multivariate logistic regression analysis. In the next step, we then taking a closer look, or the authors taking a closer look regarding the comparison between the frailty scores, the hand grip dynamometer, the clinical frailty scale, and the Edmund-Frail scale, compared to the objective parameters of age, VR12, PROMIS, BMI, Charlson Comorbidity Index, and ASA grade. And we can see that these frailty indexes are partially represented in all those parameters, but the best correlations are still a moderate and not a strong correlation. So the best, let's say, pairs we observed were the patient-reported outcome measures, which then correlated to the frailty indices with also several questions on clinical frailty and complex frailty. So what are the main findings the authors found out analyzing all these data sets? ACD patients had significantly worse baseline comorbidities, disability, and frailty compared with ATLD patients. The strongest correlations between frailty measures and other baseline parameters were between physical function scores and the CFS and EFS as the frailty parameters. As I already mentioned before, these correlations were only moderate in strength, suggesting that the CFS and EFS assessment captures some information overlapping with current patient-reported outcome measures, while also reflecting a unique measure of patient health status, though they are not all included in the patient-reported outcome measures. There are also some further important factors. And increasing age correlated with worse frailty measures, but these correlations were weak and definitely not as strong as patient-reported outcome measures of physical function. So coming to a conclusion, ACD patients had worse baseline characteristics on all measures assessed compared to the ATLD patients. These differences may help account for greater risk of complication and all-cause mortality previously observed in the ACD patients and facilitate strategies to better provide preoperative optimization for those patients. And of course, further analysis are required to reveal why these populations are so distinct, why there's such a large difference. Thank you very much.
So thank you, Dr. Swintner, for this excellent presentation. We are absolutely on time. It's just 1 hour and we made it. But I still do have a comment, as always. This study gives us an important insight on why cervical deformity patients tend to have worse surgical outcomes compared to thoracolumbar cases. And this nicely done study by Justin, we know him very well, they compared over 600 patients, and those patients, even before surgery, had significantly higher frailty, more comorbidity, and worse physical function at baseline. And an important question is what is the reason for that? And Dr. Swintner, the question is for you. And what do you think, what other factors do you think contribute to this distinct risk profile of ACD patients? What is the reason for that, even before surgery? Do we have an explanation for that?
That's a really good question. Honestly, I was quite shocked seeing that the mortality within 1 year is 10-fold higher compared to the thoracolumbar patient. And then you, of course, start thinking, what's the reason for it? Cervical means you got a higher level of the injury or the compression, and also compression of the spinal cord. So you got affection not just for the lower extremity, also for the upper extremity. And from my experience, it's also that the patients suffering from thoracolumbar deformities often suffer impairments regarding the walking distances, and also may often or much more often encounter also pain, and maybe therefore see a doctor earlier. Regarding the cervical patients, maybe they experience less pain, and also when all the 4 extremities are affected, you move less, you show less activity in your social life, and then the whole system starts deteriorating much more. And maybe then when those patients are on the operating table, even if they have the same age, the physical or effective age of those patients might be high, and those patients might be in less good clinical status, because the disease of the cervical deformity is much more affecting the overall status and system of the patient.
Yeah, thank you very much. This was a good point. I mean, these patients have some neuromuscular conditions. They have multi-level spinal cord compressions, drop head syndrome, and prior surgeries, of course. So thank you all very much for attending the virtual journal club in cooperation with the Global Spine Journal and and the Seattle Science Foundation, of course. So, and thanks for Dr. Chapman for joining me today as a co-moderator, and for having us all with you today. And it's, of course, a big, big pleasure and a big honor to be with you guys again, as I would like to say.
Hey, so congratulations to you guys and your team. Very, very impressive. So important. I'm going to put the challenge out to you. So we're all faced with more and more elderly patients. And with your data wealth, I do think that the current risk scoring is not appropriate and not helpful. As well constructed and conceived as it might have seemed, I think with your data, you can actually help us as clinicians far more stratifying what's necessary. For instance, cognitive scales, for instance, sarcopenia, for instance, osteoporosis severity. You can see we have sunshine here in Seattle, so they have to put the blinds down. I was getting blinded. But this is my challenge to you, this outstanding group of young clinicians. You can take us into the next generation awareness of how to stratify these patients so we can risk optimize and then also report accordingly. So thank you so much. Really fantastic group. Amir, any final thoughts?
No, this is great presentations. Thank you for all your work, and I think you bring up great questions and give us, as we work towards this global perspective, to have you involved is just a great addition to the advancing of spine care, and we really appreciate your input.
Thanks, Amir.
All right, have a great day and a great weekend, everybody. Thank you, Heidelberg.
Goodbye.
Campaign.